So this panel is about data and compute in healthcare 2030. So we have a big opportunity, as you all know, with the advent of AI, well, not the advent, the overwhelming flood of AI in our industry, and some really good opportunities for how we're going to get data to actually flow. Wow. How we're going to get data to actually flow so that we can use that compute power to make good things happen in our industry. So to start out, we'll start with Karen to introduce themselves. All of our panelists are going to give a brief overview of who they are and why they matter, why their voices matter in this conversation. Go for it.
Good morning, everyone. Great to be here. Jen, thank you for your great, outstanding leadership and for inviting me to be on this panel. Great to be here. My name's Karen Finger. I'm our global lead for Connected Health Strategy and Innovation at Verizon Business. You know, we're seeing an unprecedented amount of data coming from an enormous number of different types of devices, Internet of Things, Internet of Medical Things, applications, point solutions, just massive amounts of data being produced out there. In order to get that data to be accessible and where it needs to be, we maintain and advocate that it needs a reliable, secure, robust, resilient network. This panel and the theme of Healthcare 2030 is around data and AI being the engine, data, AI, and compute being the engine for transformation. I'd like to amend that to say the network's actually that foundational strategic layer. We view it as a strategic asset to enabling all the other things that come on top of that. So at Verizon, our point of view is that the network is that strategic asset. In my role specifically, I work with healthcare leaders across the spectrum, from health systems, the med tech companies, the health plans, and our technology partners within our ecosystem to co-create a unified network platform, a connected health platform, if you will, that brings those clinical and operational use cases to life, that enables and accelerates innovation, that equips our clinical workforce and staff with the right tools and connected solutions to reach and access patients, all with the hope and promise to deliver the future of more personalized, proactive, and accessible health for patients.
Lisa.
All right. Nice to be here with you today. My name is Lisa Moneymaker. I'm Chief Strategy Officer for Medidata. Medidata is a software and solution provider in the clinical trial space, most specifically and primarily in clinical development, so between drug discovery and commercialization. Since we're data-based, I'll give you a few data points. We see at any particular day, we're running about 8,000 clinical trials on the Medidata platform. We see about 200 million data points a day, which is about 70 billion per year. And 72% of the FDA novel approved treatments in 2024 were run on our platform. So we see a fair amount of the data that contributes to a clinical trial. We've been working with AI-based solutions for the last 10 years or so, and there's been a dramatic change in what our customers, the pharmaceutical and medical device industry, is willing and excited to use just in the last 3 years, since about late 2022 or so, when ChatGPT comes and takes over the world, and all of a sudden everybody wants to know how they're going to be using AI. So really excited to have this conversation today and to participate. Myself, I've been in clinical information systems for my whole entire career, so about 25 years now, always supporting the development of software solutions for clinical trials. So really excited to be here with you.
Thank you for having me. My name is Jill DeGraff. I'm at b.well Connected Health, and my role is as Privacy, Regulatory Affairs, and Compliance Officer. And to understand that mouthful, it's to understand that b.well Connected Health was founded over a decade ago, before the Cures Act was even established, with a very strong conviction that the patients need to be at the center of their health experience, and they can only do that with access to their data. And then just to preview some other ideas here, if we need to create a burning platform of how we're going to meet the objectives of 2030, it's really around the entire industry taking a strategic view in how they're going to participate in bringing fire architecture, interoperability into their own stack, and then being able to bring data from their own stack across to other enterprises. So when we think about the engineering of transformation, b.well is participating by building the infrastructure in the engine room for that kind of transformation.
Good morning. My name is Dr. Kirk Grothe, and I lead public sector strategy at InterSystems, where I try to drive positive impact to our federal, state, and local customers. InterSystems has been a partner to the federal government, state and local government for more than 47 years. We power 2/3 of all medical records in the United States and more than 1 billion with a B medical records worldwide. We're proud to be the backbone of healthcare interoperability. I'm excited to be here today, and thank you for the opportunity to speak.
All right, now we're going to get into the gritty stuff. So I go to a lot of panels, and a lot of tech company CEOs or whoever is speaking there tells me all about how AI and it's going to change America and it's going to revolutionize the world. But the reality is, and many of us up on this stage know this, and many of you in the room know this, we don't really have a lot of data flow in healthcare, and the data that we do have is not very good. So it's hard to imagine a world right now where we're going to have a transformed AI world where we're talking to the AI nurses, don't throw up, Lisa, without having that data flowing. So we have there's some bright spots, right? There we have some interesting initiatives by the administration to get data flowing more effectively. Like Mr. Posnack said, info blocking, we have the CMS interoperability initiative and some other things. So can you all talk about how we get the base foundation for transformation and compute going by getting data flowing? We'll start at the other end. Kirk, go ahead.
All right, so when we think about that base case, we'll consider sort of the 3 C's, connectivity, compatibility, and context. As we discussed a little earlier, the infrastructure layer becomes really important to bring that forth together, and that gives us the base level of connectivity. When we start to think about standards and drawing all the content together, that's when we're really considering the compatibility layer. And for context, and think about agentic AI, things like that, we really need the context to come together as well. So if we're thoughtfully considering all of that kind of stuff together, what we need to understand is that it's just not one piece or two, it's all of those pieces coming together to try to build a sustainable framework to make that happen.
What I think about is that you have to identify the business case as well as the use case. And I'll give you a good example of a business case. The current administration has decided to train its sights on the amazing profits of the Medicare Advantage business, and has decided we're going to ratchet pricing for Medicare Advantage. What does that mean from a business case perspective for a significant portion of our industry? It means that the silos, the sort of people, processes, and technology that are currently used to administer that business have to be re-examined to drive better margin optimization. The only way you can actually do that is by taking the strategic view at your own tech stack, figure out what you're going to do to interoperate so that you're not operating in data silos. In addition to that, you look at the other tea leaves of the regulatory environment. You look, for example, at the Medicare physician fee schedule, where there is now going to be a focus on health outcomes, on creating peer-to-peer measurement between physicians that are providing the same kind of care, cardiologists, for example, or doctors that provide low back pain management. And you start realizing that you're going to have to evaluate on outcomes. And the only way you're going to be able to do that is by creating a data model. But then the next stage, and this is, I think, really important as well, from a use case or from a strategy perspective, is because it's such a huge and complex endeavor, you have to participate to try to lead and help drive what the first priorities from a strategic roadmap perspective are as an industry. Build consensus, participate in the things that matter most to you, and then try to drive those standards. Because as I move over to the next panelists, I just want us to think about what we need to go beyond interoperability is is unification of our data models. And we can talk about that more.
I agree with the previous, that interoperability is key. I mean, FHIR's been a key driver towards us being able to really exchange in real time the kinds of data that's needed, but we don't have the sort of penetration that we would need yet. We still have a lot of clinical sites that are paper-based. And so there's no standard that helps for that. And so we really need to get the technology enablement up to speed, you know, for technology providers like myself. So most of the companies that are trying to put out new drugs, so we believe that clinical trials are healthcare, that it is a key driver for what a lot of patients out there are needing in order to progress their spaces, is also a global, it's not something that is just in the United States. And so now we're moving into different standards and even less technology-based solutions and even more paper. And so it really is a challenge to bring all of that up to speed. You know, I'll challenge the idea that there will ever be a single standard for all of those pieces together, but I think one of the great things about AI is it actually does give us a lot more flexibility in how we bring different data sets together. I think there was a mention of agentic before. There are some really cool new processes coming out that are sort of leaping us beyond the idea that like my box of data needs to talk to your box of data by matching up directly. And so, you know, I encourage us to really be thinking into the new technologies of data to say, how could we share and communicate in ways that are taking advantage of the new kinds of flexibility? AI doesn't always have to be shoving a chatbot in front of someone. There's a lot more that's going on behind the scenes that can really drive how we can take advantage of the aspirations that we've had, but doing it in new and exciting ways.
I have a whole list here of things we think about, but I'll just hit on a few. So it starts with our own network and how we think about our own network and making it AI ready, leveraging AI for building our own, you know, sustainable, scalable, secure network that's self-healing. Then also partnering with companies like NVIDIA to bring compute to the edge. So compute is closer to the point of need, both within the four walls of the hospital and beyond the four walls of the hospital. Then we take that and we think about the cybersecurity risks involved as more and more digital health solutions are being deployed, and especially as care is moving into the home, it's really expanded the attack surface, exposing more vulnerabilities for the bad actors. Healthcare is probably one of the top industries, right, that's prone to ransomware attacks. So we think about all these things as we work with our health system, healthcare partners to build, again, that AI-ready infrastructure that can, again, move data seamlessly, both within the four walls of the hospital and beyond the four walls of the hospital.
So a gritty question for our panelists related to exchange methodology. Lisa, so what you're saying is I've heard a lot of good conversation about maybe we don't need to focus on one standard of how to do things because the world's changing. There's going to be, you know, more language-based interoperability, things like that. And FHIR, you know, and I represent large HIEs and large private networks, let's call them that don't really depend on FHIR, right? All that stuff is still done via HL7 ADT, and we knock it over, right? And it works just fine. And so a lot of the conversations I have are like, no one's really using FHIR. And I did this morning because I hear it all the time. We need to be using FHIR. Been hearing FHIR for years and years and years. But the reality is, and I tried to fact check this on the internet, but I had to ask a very online friend, Brendan Keeler, friend of the Health Tech Talk Show. I was like, how many people actually use FHIR for exchange? He said of business associates, it's only 20% on a good day. So my question is, we need willing participants to actually work together to use FHIR, but should we be focused on that at all at this point? Or can we move to something else? I'd love it if each of you could answer that.
I'll go quick. I think it's still critical. I think that it still plays a huge part because a lot of what we see in lack of FHIR adoption is actually change management and the physical site adoption of that and the feeling permission to be able to participate in it. And no matter what technology we use going forward, it is going to build upon that same idea of permissioning and change management. And have we gotten to the idea that we can share anything? And so I don't think we should stop because it is groundwork now for anyone that wants to jump ahead and skip to the next new thing, great. But I don't think we should relax on the idea of encouraging and promoting this idea that sharing is caring, sharing is good. We want to have interoperability, and FHIR is a great step towards that. And we've got a ton of systems that are built and ready for FHIR interoperability. So we should not take our foot off the gas. We should just recognize that it's probably not the end point. It's probably not where we finish up. And we probably never finish up. There's no stopping point, but it is still a great waypoint along the way.
I'm actually baffled and curious as to why blockchain hasn't been used more prevalently.
Oh my
no
God.
one said blockchain yet, but like, is anybody using blockchain out there? Like, to me, that seems like
Anybody using blockchain?
It's, yeah, we should be, right? I mean, especially for patient-centric, what? Credentialing. Yeah, credentialing. There are some use cases, yes, coming about, but even like clinical trials. I was working with one company that wanted to launch a blockchain platform for clinical trials. Patients' data is in all different places. You may go to a urgent care and you have your data there. You may go to a CVS Health and have your data there. You go to the emergency room or the hospital. Patients' data is all over the place. If the patient could release their data, and then the providers and clinical trial, people.
Yeah.
Yeah.
Well, and the idea of tokenization or blockchain or knowing who you are is a critical first step. But even once I know you are you and you have consented to share something, I still have to share the thing. And so, then we've got all the data that still needs a standard or a mechanism or something to pass it from right to left.
So I'm going to answer your question.
Love it.
Which is that there should always be the concept of a multi-threaded interoperability strategy. There should be many ways in order to transport data and the types of data and the formats of data. Even today, FHIR, which is on an evolving data standard, will continue to evolve, but likewise, network-based interoperability is built on a standard and it is necessarily constrained. The other way is to completely unfurl the information and allow the magic of large language models to do their thing. They are all good, but they also have various trade-offs. If you actually want to create an interconnected cross-enterprise and cross-system permissioned and auditable mechanism for interoperability, APIs and FHIR are really quite fit for the defined scope and purpose. And it's really secure in that way. Why it isn't taking off yet, Mr. Keeler, is because there are games that happen below the surface. And by the way, we talked to Mr. P about all those kind of issues, and we hope that we will see much more defined guidance and FAQs about those games that happen below the surface. A good example, and it happens with one of our own customers who uses our platform in order to build all their data, create a FHIR server in order to drive population health, understand their high and rising risk populations so they can define specific digital interventions, health programs for different populations based on their particular needs that are then in turn tied to quality measures and being able to perform effectively in ACOs and then pull the other providers across an ACO into the same model, and all the while provide transparency of that information and provide engagement through a digital front door solution for patients. When you are able to take FHIR and support a multiplicity of use cases, that's very powerful, but you're also doing it in a way that's very responsible from a data stewardship and governance and security perspective.
So I think it's a long time off before we have a single transmission protocol that everybody's going to use. I think that there are market-based differences in the way that people transmit information. That's probably going to continue among market segments. If we look outside the US as an example, OMOP is everywhere. And if we're thinking about medical research and clinical research and those kind of things, that's going to continue to be the process. I think that a control model is probably a little too late. I think that we have to think about interoperability as what are a collection of standards that we can process in a meaningful way with a set of standards that allows us to maintain scale and reliability in a sustainable model. And when I say sustainability, not just some of the things that were talked about early, but also when we think about environmental sustainability, because there's a significant amount of overhead in being able to process those transactions, and we have to consider those things as well.
Last question, it's a yes or no question on the data stuff, and then we're going to move on to fun stuff. Do you think the CMS interoperability pledge is going to work? We'll start with you, Karen.
Of course, yes.
Yes, in the sense that I think we need both push and permissioning, right? We need a shove in the right direction. We need the instigator that often allows us to prioritize things higher than they otherwise would have been, because there's a million things that everybody and every company needs to do all the time. And so if we have something that instigates, we often just need the instigating force. So let's go with yes.
So somebody to say no. In full disclosure, b.well is a pledgee as a CMS-aligned network, and we have a number of our clients that are also supporting the pledge through some of the priority use cases that have been identified. So yes, we believe it will be because we're invested in it, but also I think back to the timeline that Steve was sharing, which was in 2015, there was a hypothesis around interoperability through APIs. It didn't actually start through regulation. It started with Apple Health Record and Glimpse. They acquired Glimpse, and all of a sudden, guess what happened? Apple Health Record was launched, and all of a sudden there was fear of missing out as the main motivator. All of a sudden, a bunch of other health systems said, I want in too. They didn't have an intrinsic business interest. They just knew that it was the future and they wanted to be there. And that's the kind of energy that I think is going to help differentiate this movement from others, but also provide the potential for success. One other piece around it is that the interoperability framework is also indexed towards innovation and competition. And it's very clear that this administration at least understands that winners should not be picked on the basis of who controls the data, which is in many respects a function of the interoperability or of the healthcare adoption payments that were made 15 years ago. And so what we should see instead is value to be created in the marketplace on top of the data, with the value, the kind of opportunities that are provided by Medidata and others to really help patients, help create an ecosystem of different solutions.
All right, 3 yeses. What are you going to do, Kirk?
Well, I'm a yes as well. And when I say yes, I think if we all agree to behave a little differently and we act a little differently together, we're going to be able to shake out some of the nonsense that may take place in the industry, some of those underlying issues that you've been discussing. And if we're able to do that, we're probably going to get closer to true center.
Awesome. All right, let's move on to some fun stuff. So we're talking about how we get the data. There are a lot of cases where we do have the data, right? Whether it's in current health systems that have their own data, or we've been able to procure it from various sources in a patchwork kind of way. And there are some really early, good, promising use cases for the power of compute and how it can revolutionize patient care, improve outcomes, increase efficiency for clinicians. Can you all work through a case example for me of how you're working through that in your current roles, assuming either that you have the data or it's coming soon? Let's stop talking about data. We'll start with you, Lisa, because give me a case example. Walk through a case example where you're seeing the power of compute really change.
Yeah, so I'll give you, this is going to get a little geeky on clinical trials, but clinical trials have fundamentally been the same for the last 25, 30, 40. I mean, they don't change all of that much, the general process of what we've done. And we think there's huge opportunity in both the data and the technology that's available to us now to change that. So for the last 20, 25 years, if there was a new system that came online, it was to give a data collection opportunity to augment a current process. But like I said, the process itself was largely the same. And I think we all feel that there's this feeling that clinical trials should be able to go faster. We want to be able to move with the same efficacy and safety concerns. Like there's a reason that they are onerous and take so long. It is to protect all of us because we are all patients at some point or another in our lives. And so what hasn't changed though is this idea that now with data, and this is something that we're working on, we actually have the power now to be able to use historic data and the choices that have been made to take the power of artificial intelligence to simulate data, to simulate what patients might look like in the real world, and combine those two things to simulate a trial. To be able to say, I'm gonna be able to go into this trial. And we're not talking about the mechanism of action of the drug or the drug discovery, but this idea of how might it operationally proceed? Am I likely to hit my enrollment curves? And that's one of the key deciders of whether or not trials progress is, did you get enough patients? Were you able to find them? Could they get onto the trial? Did they want to stay on the trial? Or did you ask them for too much? Did you demand too much of them and eventually they go, I'm out? And so we believe, and we're working on case studies right now around that, the idea that we could simulate a trial in advance so you would know what are the changes I need to make early on to raise my likelihood of success, so that the trial isn't failing not because, or excuse me, the trial doesn't fail because I operationally couldn't complete it, that the trial fails because the drug wasn't safe or effective. And those are the good reasons for a trial to fail, but we want to get to those answers sooner, or get them all the way to progression so that we're getting the necessary generated data for success. But I think that things like that can actually have a fundamental positive change of outcome of, this is a new way to think about the running of a study itself.
Love it. Jill.
One thing I like to say is that the best healthcare a patient ever wants is the healthcare they never need. And I think about that when I went to get my primary care annual visit done, and then a week later, through one of our customers' apps, out came the results of my labs, and then with real insight around it. And so again, I checked the box, I went and I did the health visit, but I actually got meaningful information, which helped me start pulling on a thread. And so that idea about convenience, about empowerment of patients, well, is something that we can actually do at scale. Because one other thing that we have, I'll be a little cheeky and say, with some asterisks now, we have reliable, well-vetted, evidence-based guidelines. And from that, we can translate that into an intelligence layer to create true personalization and insight.
Kirk.
So I have two quick examples. The first is we have customers in 2 jurisdictions that are working together to bring in both social determinants and social needs data in along with the medical records to support 2 different types of use cases. The first use case is around behavioral health and having a 360-degree view and support some of those activities. And the second is working with children's programs to support outcomes in urban communities, which is kind of awesome. The second thing that we have is within our own software, within InterSystems, we have an AI co-pilot. And that AI co-pilot allows providers to look at a longitudinal record, bring in content from various sources, and start to ask questions that might be contained deep inside, like, can you summarize relevant cardiac history or something like that? And those kind of things, being able to track all of that in during the visit and have a different kind of conversation with the patient in real time is impactful for them.
Yeah, I'll give a couple examples. So one, we're seeing like data and AI really being leveraged to make a hospital smart. So with the shortage of, clinicians, and it's even getting more and more challenging, the hospital really is becoming a member of the care team, where through data and AI, it's an assistant to the care team, telling care team, the status of a patient, monitoring that patient in real time, delivering that data, enabling and tracking assets throughout the hospital, patient flow throughout the hospital, optimized scheduling, et cetera. There's like huge list of all the things that data and AI is doing within the 4 walls of the hospital. Predictive analytics on fall detection. All those things, though, we're seeing is really causing a strain on the Wi-Fi networks within the hospital, the legacy infrastructure. So where we're getting heavily involved is working with health systems to modernize that infrastructure, that legacy IT infrastructure, such that it worked through our private 5G network. So it works, it's inherently more secure, it works seamlessly, it's more agile, it really enables the health system to leverage the full power of all that AI and data. And it's transforming the patient experience too. So the patient, within the patient room itself, making it smart, controlling the environmentals, asking for food, medicine, et cetera, enabling the nurses to operate at the top of their licenses so that they, through like virtual nursing, virtual discharge. So leveraging all that data, bringing it together on that cohesive, agile, smart, intelligent network platform is one piece, and then extending that out into the home, again, privately and in a secure, uniform fashion. And bringing as well into rural communities. We've worked on, and we're working on supporting an ARPA-H program as well around delivering advanced hospital capabilities into rural communities through the network platforms, being able to overlay in augmented reality for remote expert task guidance. So there's just tremendous promise that if you can deliver and get access to the data and get the data where it needs to be and get it into the clinician's hands for intelligent clinical decision-making, right? We can really expand and scale and transform the healthcare delivery system.
None of us are medical doctors up here, is that correct?
I grew up in a medical family, but no, so.
Yeah. So how are you all?
No, I'm the researchy and evaluation kind.
Oh, you're a doctor.
Yeah,
You
but-
are a medical doctor.
No.
Oh.
I'm the researchy and evaluation kind.
Okay.
Not a medical doctor.
Okay. So how are you all incorporating clinical feedback into the use and building of your AI tools?
I spent a lot of time actually talking to clinicians and doctors, and our role is to, like, you bring the clinical, we'll bring the technology, and let's co-create something together. So then I ask my dad sometimes.
We have MDs and PhDs within our data science group that help us formulate what the model should look like.
At b.well, we're a technology company, so we actually pretty much put up pretty rigorous guardrails. We will apply evidence-based guidelines, but then what we're also doing is we're benchmarking that to NCQA HEDIS measures so that we can actually to provide some independent assurance around those use cases.
I also ask ChatGPT quite a bit, actually.
Yeah. Miriam, looking at you.
So we're a software publisher by organization, but we have a number of clinicians, physicians, nurses, other folks like that, other types of researchers that are part of our team, so that when we develop the solutions that are used globally, we make sure that they conform to medical standards. We make sure that we coordinate with all of the rules and regulations that take place there, and we focus on two things. First, trying to make sure that the tools are available to put the patient in the driver's seat, and second, to make sure that the clinicians and providers that are using that technology can have enriched conversations with those people.
Actually, I have one more thing to add, sorry, is nurses are the heartbeat, understand the workflow. So the more time we can spend with nurses to really figure out how can we help optimize, right, through various connected solutions, and also the informatics officers, often they're clinicians, also a wealth of information to really track the patient experience and HCAP scores and star ratings, and really, I mean, if you can move the needle on just an HCAP score, that, and we've got some ROI tools we're starting to leverage where we can weave in that data, and it can have a tremendous financial, like, ROI benefit.
Love it. And one thing to add as well, from a clinical trial perspective, the idea of clinical decision-making is highly regulated. And so for us, anywhere where the AI might be surfacing something that lends to clinical decision-making or coming up with the next best action, there's always a human in the loop. So ultimately, the human is taking the decision on what happens next, supported by anything that AI could potentially surface up or provide to them. But we leave the human in the loop. At least for now, we'll see where both technology and regulations go, but that's a critical part of our workflows.
Love it. So Lisa, another question for you related to clinical research, at least in my world with data, right? A lot of times research is not included in data use agreements in our industry. So research, clinical research has always been a little bit outside, but there's a ton of interest in how getting the data to you all can make a huge difference. How do you suggest bringing your category, because you're in our industry, more closely together so that we can have great advancements in AI using that data?
Yeah, I mean, it's a big topic of conversation right now is around the overarching consent process, both from kind of the wall between the clinical side and the healthcare side, as well as just in the introduction of artificial intelligence. There's a lot of talk going on right now, not just in the US, but in other countries as well, because again, we've got to sort of find the unifying factor between all the different regulations to make sure that a drug that is researched in, you know, the UK and France and the US can be marketed in all of those. You've got to apply to all of the different regulatory aspects. But when it comes to consent for AI, there's a big debate about whether the consent that is given for the data to be examined in the context of it, does that extend to being able to use it for AI training that would also be in support of that, or do you need another consent that's on top of that? And that's evolving right now. But I think from the perspective of, you know, we were talking about blockchain and tokenization, et cetera, a little bit before, you know, there are mechanisms right now where within the clinical setting, you are able to request of the patient at the time of, can I have access to your medical health record as well? And when we do that, that really opens up this entire idea of, you know, the longitudinal access to the patient. So then in the future, we can say, I can examine longer term health records for the context of how might this drug have performed in a different patient population or over time, et cetera. So I think really starting to explore different ways, and we do this, you know, in a lot of our FHIR connectors as well, to be able to say, you're at that point, you have a point of care that is the unification of that patient in the real world and that patient in their participation of a clinical trial. Can we get the consent from them then? So I think it's really just kind of exploding that workflow out, which is only at its beginnings, but you've got a lot of real world health data companies out there in search of a problem. Like, I have all of this data, can you search it for something? And the answer is, until we can identify that and link it to something, no. And there's a lot of hesitancy there because we really don't know whether there's anything of value in it. We talked at the very beginning, or the last panel was talking about, you know, let's not ignore the commercial concerns here. So it would be great if we could link all the records everywhere for always. But unless there's something to be known that has commercial value, that's a really significant investment that people don't want to jump into. So if we could find a pathway to make that a lot more accessible, it would open up these doors, because the answer is probably yes. We just don't know what the answer is at the time that we don't have the question formulated. So that wasn't a solution. It was just describing the problem.
I mean, are you seeing like digital twins in your area?
Absolutely.
And can that replace using humans for clinical trials at some point, do you think?
At some point. So we already have technology that we've used quite a bit. We call it a synthetic control arm, which is using the idea of patient populations as a replacement for either placebo or standard of care arms. And that's really been tremendous, because anytime, if you have a terminal disease, the last thing you want is not to be on the investigational drug. If your standard of care or placebo is not going to give you an extended longevity of life. So especially in trials, and we've had FDA approval, where the standard of care or placebo is simply not acceptable, is not, you know, an advancement of care, where we can take these standard of care arms, these synthetic control arms, and use those, and that means that the vast majority of patients get to be on that activated drug, and that's really been tremendous for advancement of care.
I think from the standpoint of our goal today with Healthcare 2030, a really important idea is that we democratize access to clinical trials. And the best way to do that is to leverage some of the infrastructure that exists today, patient registries and the communities surrounding them, giving them the tools to be able, under the individual right of access, to give data immediately, provide value on that data for the patients, but then allow the patients to make choices about contributing that data to a registry for real world evidence, for making it easier to find those needles in a haystack. Our CEO's daughter has a rare disease. For many years, her family believed she was the N of one patient with her particular condition. When her doctor left Hopkins and went to a different academic medical institution, she called Kristen and said, I found more Baileys. That's the joy. It's actually a joy for the patient community to know that there is a possibility for faster cures, and we can all work on that. And really, with patients in the center and having autonomy and choice to make in how their data gets used is a really important value, I think, for our 2030 goals.
You don't have to have any feedback.
I don't.
Love it. That's what I'm talking about. All right, so we've just got a few minutes left here, and I kind of ignored the question I hate the most, which is governance. But we're gonna end with this question for you all, and that's that we all want to get to this world faster, where we've democratized access, where we've expanded the ability for clinicians to work more effectively, all that stuff. In the past, public-private partnerships have been leveraged to scale these types of efforts with governance and responsibility. Do you think that's the best path forward here for the power of compute and getting data out there, or is there a different way you think we can get there faster? We'll start with you.
Sure. So I think public-private partnerships certainly have a place. With some of the pledges and other things that are being brought forward, I think there's an opportunity to try to speed up the scale and the speed to benefit. But historically, some of that's been an inhibitor. There are other models that are out there. We can think about cloud-native architectures, federated computing ecosystems, stuff like that. But more importantly, I think there's got to be a collective commitment for everybody to want to operate differently. And that doesn't just include for the base interoperability kinds of things. It also includes concepts like consent, which isn't just something that a patient does so that they can have something done to them. It's really a foundational component of trust. And once that trust is sort of executed, what happens in that service chain to them?
Love it.
I feel like I said it in my last remarks, so I'm going to pass.
I mean, I'll echo that. I think it is a way forward. It may not be panacea, but I think it absolutely expands with a couple of, both goods and caveats. So from a good perspective, I'm really considerate of the fact that the data that we have that is available is not always representative. So the folks that have had better access to healthcare over time, which, tends to be white men, as opposed to minority groups and women who weren't representative in clinical trials until the late 90s. That means that when we derive models on them, they have a tendency to look like a specific population and less like other populations that also should have access to care. And I think that public-private partnerships gives it the ability to see more data where we may be able to do better work debiasing the data and finding more representation in it. There are techniques that we can use to do that, but you've got to have things to model it off of. So I think public-private partnerships can really do a great job in helping us expand the amount of data available. I think the caveat goes back to the commercial models. I think the thing that we often ignore when we say, let's just all pool the data, is a lot of people have spent a lot of money getting things in a shape that they can make use of it. And they're not super excited about just dumping it in the pool and having, GarageBand X jump up and be like, I can be a provider too now. So finding ways to allow for a public-private partnership to remit remediation back to the companies that are contributing, that have invested over time in being a part of this ecosystem, would make them far more willing to participate in that, which would really drive for adoption of it.
Speaking of driving for adoption, I would love to see the Affordable Connectivity Program come back, the ACP. We were leveraging that quite a bit with some of our health plans partners to provide digital inclusion and access to broadband connectivity, wireless devices, to participate in things like clinical trials, chronic care management for preventative care, things like that. So patient member engagement. But also would love to partner with the FDA to fast track embedding cellular connectivity in medtech devices. That's a big hurdle in the ecosystem. A lot of the medtech devices, so any medtech companies in here, if you're building new or you have existing, please build in cellular connectivity into the devices. That is a big hurdle to realize the dream of ubiquitous connectivity across the ecosystem. One of the challenges we see is with medtech companies that have already built their devices, if they go back to try to retrofit the cellular connectivity, they have to go back through FDA approval. So if we could work with the FDA to fast track that, that would be nirvana. But then also, when you're building new devices, whether it's Verizon or another provider, consult with your connectivity providers. It's a big untapped resource.
Love it. Well, thank you to our panelists, and thank you all for staying and listening to this conversation. It's time for a break.